So let's talk about a case study. And I actually was at Beacon Health Options at the time that we started one of these provider-led Arkansas shared savings entities, or PASSE, as they're called in Arkansas. But I think it's a great model, an example for what the future holds. And again, tying back to some of the points that you made earlier, Monica, about populations, is that in this particular situation, the legislature in Arkansas legislatively mandated in 2017 a structure to manage roughly 30,000 high acuity, severely mentally ill, and high acuity IDD individuals. And in just the state of Arkansas, those 30,000 people spent $1.13 billion. And again, you don't have to be a financial genius or an actuary to realize that is a lot of money on an individual basis. So but the goal there really is to reduce the unnecessary spend really on the medical side. And I think, they call it in Arkansas the halo spend, but it's really about managing high-risk individuals and giving them a high level of behavioral health services that really does have an integrative approach. So the original model was the startup, and it was really around creating these, I'll call them forced marriages, but it was, and we'll talk about what the components of that look like, but it was really to case manage these individuals for the first year, which would be 2018. I'll give you an update on where they stand today. But again, the state will still pay claims. The full risk was designed to start in January 1st of this year, where the entity itself, the PASSE, paid the claims, and they took full risk for physical health and mental health for these 30,000 individuals. So there's three companies basically that met the requirements of a PASSE. So, and it was an application process that they had to go through. It was, very similar to trying to gain a HMO license. And then just as a tangent, Optum won the contract to do the assessment and the attribution of the members, these 30,000 individuals, as far as, where they were going to land initially. So then if you look again at the model itself, the state wanted this to be provider-led, provider-driven, which I think, again, is a symbol of what's coming. So again, as people think about, what do I need to do to prepare, provider-led entities are, going to become something that'll be powerful in terms of being able to drive results in a population health model. But again, in Arkansas, the partnerships were legislatively mandated to include a licensed or certified direct service provider of developmentally disabled services, a licensed or certified direct service provider of behavioral health services, a hospital or hospital services organization, physician practice, and then a pharmacy, a pharmacist that's licensed with the state of Arkansas. So this was their secret sauce, so to speak. So in each one of the three passes, there was also a payer that was involved, because again, you still have to manage these individuals. There still is financial risk that exists within these partnerships. But the partnership itself, it had to be 51% owned by providers. So again, they modeled the savings in terms of what the state expected. So they were pretty much going to take their money kind of off the table up front, hopefully. So in 2016, Arkansas looked at the Tier 2 and Tier 3 population, which again are these severely mentally ill and high acuity IDD population. And again, out of that $1.13 billion that they were spending out of the Medicaid system, what they were really targeting is the halo spend. And you can see on this slide here that $458 million were spent in the severely mentally ill or behavioral health category to make up basically the total spend of $731+ million in total spend for the severely mentally ill population within Arkansas. So again, the state's belief was that we would be able to shift, if the appropriate treatment happened in the behavioral health setting, the physical health costs would drop. And that's what that halo spend is. It is literally the shifting of that cost and decreasing that cost as a result of appropriate treatment happening. Same thing with IDD. You can see that the number's a lot smaller, but it still makes up $83 million of total spend, which overall represents 21% of the Tier 2 and Tier 3 high acuity IDD population. So again, we're talking about very large dollars. And this phenomena exists across all of healthcare. So again, that's the reason why there's a lot of attention on this Arkansas project in terms of what results they will see as a result of this PASSE program. So as an update, we saw the original dates, but the case management actually began on February 1st, 2018. So that they basically spent 1 year on a case management model where they were just basically being paid a per member per month just to basically oversee in a case management model this population. And then the PASSE, all three companies went at full risk beginning in March of this year. So they have been operating in a full risk contract. I mean, the question that will be an obvious one is, you know, are they implementing value-based payment methodologies, and are they really leveraging the fact that they're managing whole person health cost, and are they seeing the increasing quality? And frankly, none of the passes from what my intelligence has said is that they really haven't had an opportunity yet. They've been really doing the administrative piece of this and really trying to get a firm foundation because the state historically has been paying claims. They are now paying claims, and they are now at full risk. So beginning, and I believe this, you'll see this next year, that all three passes in Arkansas will actually be implementing and really looking at quality measures much more pragmatically. So it'll be an interesting dialogue that they have with the providers in Arkansas from all of the categories. And again, the other thing that was discovered is that it wasn't roughly 30,000 individuals that were part of the this category of severely mentally ill and high acuity IDD. It really was 45,000 individuals, and 32,000, you know, are roughly make up from the severely mentally ill population. Roughly 8,000 were high acuity IDD, and I believe that they're still looking at the additional 5,000 members. But anyway, the numbers are roughly 15% higher than I think they originally anticipated. And lastly, the three companies that essentially went through what the equivalent of applying for an HMO license within a state, and it was an application process, ends up being these three companies. And I've noted here on the slide that who the payer is involved in the joint venture. And again, all of these are at least 51% owned by the provider organization. So you have Arkansas Total Care, which has Centene in as a partner. You have Empower Healthcare Solutions, which has Beacon Health Options, and then Summit Community Care, which has Amerigroup. So again, I think this is one that, you know, certainly attending this webinar, you'll want to continue to track and see the goings on and the savings that really will come out of this, because again, I think there's something that's very highly replicable from the standpoint of looking at population health management, and again, in this particular case, looking at some of the highest spend and the opportunity to increase quality with this population is very, very significant. So it'll be fun to watch over the coming years.
Well, it is an interesting example of a vertical, you know, a risk approach, which is I'm going to take this high use population, I'm going to put a group at risk for all their physical health, pharmacy, mental health care, social supports. So I do agree that, you know, how this works or doesn't work will kind of determine the future of this Medicaid focused vertical approach in the future.